All right, good morning, everyone. We thank you so much for coming out in this poor weather today. We're especially thankful for Dr. Darnell driving all this way from Chicago in this weather. But we're very happy to see friendly faces in the audience, so thank you for making it. We would also like you to know that we've been working on this for a long time, since about October. So this event was originally intended to be part of the Free and Charitable Clinics Week in Illinois in November. However, due to scheduling, we moved it to February. Unfortunately, the weather didn't really agree with us. But we're very excited to have Dr. Darnell here. She's the leading researcher in free and charitable clinics in the country. She has very helpful, I think, things for us to learn about today. And we wanted to let you know as well that the 4 free clinics here locally help sponsor this event, that there are representatives from all of the free clinics here locally. And if you have any questions about what services are available, we'd be happy to answer those afterwards. We also have flyers all over the place with all 4 free clinics and their information as far as services offered. If Angela's holding one up in the front, if you guys can see. And we'd be happy to get those copies to you afterwards or at another time as well. So this event was made possible due to the generous donation from the Illinois Association of Free and Charitable Clinics. So they're the ones that funded your lunch today. Thank you, FTCA, and making it possible for Dr. Darnell to come. And we also would like to thank Carle for allowing us to use the space today, the College of Medicine for helping us get CME credits. If you are looking for CME and haven't already signed in on the sheet, it's available outside. If you're looking for CEs for nursing, that's also on the CME sign-in sheet, and the social work sign-in sheet is also outside. And we'd like to thank the School of Social Work for also making this one of their free continuing education events for today. And finally, we'd like to thank the College of Nursing for also helping us publicize this event. So, a little bit about Dr. Julie Darnell. As you might have read, Dr. Darnell is now an associate professor at Stritch School of Medicine at Loyola. She just started there, I think, in the fall, so she's excited about this new position. And she earned her national reputation from her work on free clinics, which are volunteer-based nonprofit clinics that provide healthcare services at little or no charge to low-income people who are predominantly uninsured, which is something that not everybody still thinks about the uninsured. So we're excited to hear her research today. She's received numerous awards for her work, including from Social Work Research, the National Association of Social Workers Foundation, the Association for Research on Nonprofit Organizations and Voluntary Action, the American Public Health Association, the Public Health Systems Research Interest Group, and Academy Health. Later today, she'll be interviewing with WILL, so she'll also be on NPR, so we're very excited about that as well. So without further ado, I would like to introduce Dr. Julie Darnell.
I am so glad to be here. No, it really, truly is my privilege to have been invited to be part of this forum, and I also wear a hat of being on the board of the Illinois Association of Free and Charitable Clinics, and was sharing with Katie how impressed we are as a state association at the work that's being done down here across the 4 clinics, and for your coming together to provide an opportunity for us to talk about the uninsured and some of the organizations out there trying to meet that need. So today I'm here to talk about free clinics in the post-Affordable Care Act era, but thought before I jumped in that I would start by a show of hands asking how many of you in this room have worked in, volunteered in, received care at a free or charitable clinic? All right. So many of you. Well, that's wonderful to see, and thank you for your service. For those who might not be familiar with the content of this presentation, free and charitable clinics, and I'm using both terms here, and what these two share in common is they're both nonprofit entities. They both target their services to the uninsured or underserved populations. They provide a range of healthcare services, are volunteer-based, and don't bill third-party payers. But there's a point at which then they diverge. what we've seen evolve in the sector is that there are free clinics that do not charge a fee. They may request a donation, but all of their care is provided free of cost to the patient. But in the recent period, in the past 10 years or so, I've seen a new kind of entity being embraced by the sector, and we call that a charitable clinic. And where it diverges from a free clinic is that it does charge a fee for its care. And then to further add to the lexicon that we see in the free and charitable clinic sector, those free and charitable clinics that decide to bill Medicaid, we have another name for them. We call them hybrid clinics. So throughout my presentation, you'll probably hear me mention all of these terms, just so that we all are understanding what I mean by each. But all of these entities make up what we call the free and charitable clinic sector. So even though I'm asked to talk about the current experience of free clinics, I think a useful place to start the discussion is to look at the history of free clinics. So if we go back 50 years to the 1960s, this is really when the free clinic movement took shape. This is when the Haight-Ashbury Clinic in California and others like it opened its doors, and they were a response to mainstream medicine ignoring certain patient populations like the ones mentioned here, so-called drug addicts, runaway youth, and the homeless. These are patient populations that couldn't access care, and free clinics emerged to serve these underserved populations. These populations continued to be the targeted populations through the 70s, and what's really interesting, as the sector moved into the 1980s, what we see is that the patient population changed a bit as children started to be covered more and more by Medicaid, as federal funding was made available to open drug treatment programs. Free clinics moved away from their original populations, drug addicts and runaway youth, and were serving just more generally the poor. I think some of you, at least in this room, are old enough to remember the Clinton health reform debate and its ultimate failure. And what we saw in the 90s was many free clinics being founded, and they saw that the population that they wanted to serve was the uninsured, and in particular the working uninsured. And that has been a legacy ever since the 90s for the free clinics to have turned their attention in a very focused way on the working uninsured and to present day. But all across the free and charitable clinic sector history, what I see is that free clinics have been gap fillers. They have responded to where new gaps emerge and have modified what patients they target based on what needs emerge. So I think that's very important context to understand clinics today, and I think we are at an important juncture in our history to figure out what's next. So I don't know how many of you are familiar with the TV program Mythbusters. I became involved, I suppose. My daughter had a science fair experiment and was required to use a Mythbusters question to as part of her science fair experiment. So we were, for months, trying to answer the question if goldfish have memory in our goldfish tank. And what I like about the Mythbusters program is it uses the scientific method to debunk myths. And because myths are so prevalent in this sector, I thought this would be a good organizing framework for my talk today. So one impression that I think many have about free clinics is that they're insignificant. And so I'll share with you some of the evidence to debunk this impression. My evidence comes from a national survey of all known free clinics that I conducted as part of my doctoral work in 2005-2006. So it was a population survey of every free clinic that I could find across the country. And what I learned was that there were 1,007 free clinics scattered across the country in every state but Alaska. I guess that's why I've left Alaska off the map. They don't deserve to be on here since they don't have any free clinics. But collectively, across the 1,007 free clinics, they served 2 million patients and provided 3.5 million medical and dental visits per year. Their volunteers contributed almost 4.5 million volunteer hours. They're not providing episodic care, but characterize the care they're providing as ongoing. And most of them have some paid staff. I think another signal about the significance of this sector and what is contained within it is represented here by the map showing all of the states that have a free and charitable clinic association, like we have here in Illinois. We have the Illinois Association of Free and Charitable Clinics, and all the shaded states here, it's roughly half, have such a state that is serving their member clinics in their state. In 2010, I became involved in a report to the Congress. The Congress had mandated a report to look at 3 kinds of safety net entities: federally qualified health centers, rural health clinics, and free clinics. It was the first time ever that free clinics were put alongside their better known safety net counterparts. This was a sea change in the free clinic sector. For long before that, free clinics had existed largely below the radar, and here they're being asked by the Congress to be a part of a study looking at ways, how do we improve the quality of care and increase the adoption of electronic health technology in these settings. And I led the chapter on free clinics, and what we ultimately reported to the U.S. Congress was that free clinics were critical sources of primary health care, which I think is a real victory to be recognized at this level about the care that free and charitable clinics provide. Another myth that I commonly hear is that free clinics are very transient, that they come and go, that there's an impression that they don't last very long, that they close their doors. And I've been collecting evidence to try to debunk that particular impression. It's one that it's taken me a long time to come up with the body of evidence to challenge the impression, because the ingredients you need to be able to tell the story that free clinics are more permanent, you have to know what the closure rate is. And to be able to calculate a closure rate, you have to have a defined time period. And I have that finally. So as part of the work from my national survey back in 2005, 2006, as I mentioned, I had a database of those 1,007 clinics that I knew existed at that time in history. And so what I've been doing over the past 10 years is tracking what's happened to those clinics and know whether or not they still exist, or if they've closed their doors, or if something else is they've converted into another kind of entity. And so I'm able now to calculate a quote-unquote closure rate, and what I have recorded thus far is that 77 of the original 1,007 clinics have closed. So that translates to a closure rate of about 7%. So probably less than, I think, the common mythology about free clinics is that you would, I think many would expect a much higher closure rate than the evidence suggests. You might be scratching your head at this point and saying, but what's that 120? I've expanded my scope of the kinds of entities that I'm studying, so I'm not studying just free clinics as I did back in 2005, but have added to the mix these charitable clinics. And so the number of closures that I've observed across free and charitable clinics including ones that were established after 2006, adds up to 120. So there are 120 total clinics, but because I don't have a denominator for that group, it's important for me to return to the 1,007 since I knew that number and can track that over time. I think a related question is, well, now that we have the ACA, are we seeing clinics in those states that expanded Medicaid close in droves? You know, they can close up shop. What do we need free and charitable clinics for? And have tracked the location of closed clinics and can calculate the closure rate in each kind of state, and found that 57% of clinics that have closed are located in a Medicaid expansion state, which suggests to me that closure is happening across the country and is not just isolated to states that have expanded Medicaid. In addition to closures, we have sort of other dynamic forces occurring in the sector. We have 21 reported cases of clinics either converting into an FQHC or merging with an existing FQHC or being acquired by. So they're existing in a different form. They're just no longer a free clinic. And just recalling for a moment the data that's showing the closure rate of only 57% in Medicaid expansion states suggests to me that there are many other reasons why a clinic would close that has nothing to do with the Affordable Care Act. And so when a clinic closes, I systematically try to collect the news stories or talk with somebody at the clinic to find out, well, why are you closing, or why have you closed? And these are some of the reasons that I've learned are behind why a clinic closes. In some cases, a clinic could be located in an area where there aren't many volunteer providers, and a loss of a volunteer can mean that there just isn't enough staff to run the clinic. In some cases, you can read between the lines of the story and think that there was ineffective management. In several cases, the story is that the founder of the clinic has either died or retired, and there wasn't a succession plan to continue the clinic. And even things like excessive regulations. One I haven't listed here is a clinic has rented a space and the lease is up and they have nowhere to go. There are a host of reasons that lead to a clinic's closure that has nothing to do with the ACA, although certainly in a number of cases that is indeed the reason given for why the clinic is closing. What are we seeing here in Illinois? When I studied this sector of just free clinics back in 2005, 2006, just to give you a sense of the magnitude of the sector here, there were about 40 clinics, free clinics in Illinois. Today that number is exceeding 50, although I'm not comparing exactly apples and apples because I've made room for this close cousin, the charitable clinic, that is accepted into the sector. So across the free and charitable clinics that have existed here in Illinois, I've documented 10 or 11 closures. In some cases, it's hard to track down this information. A few have become FQHCs, either through mergers or acquisitions. In my city of Chicago, there was one free clinic that merged with another free clinic. And we've had 7 new clinics born. So all to say, this sector is very vibrant, it's very dynamic, but stable. Given that 93% of all free clinics that were known to exist in 2005 are still around today. Probably the most prevalent myth has to do with suspicions about the quality of care that this sector provides. And I'm sort of using this quote, real doctors don't work at free clinics. to relay an experience that I had when I was piloting my first survey, and I was going around visiting clinics and sat down with the medical director of one clinic, and she sort of whispered to me, well, she was so proud of her clinic. Well, we provide excellent quality care here. I don't know about those other free clinics. So even in the sector, there is this suspicion that not quite sure about the quality of care being provided. And it's a fair question to ask. So let me bring to the table some evidence to help assuage her concerns and others like her. So I'm going to start with the Federal Tort Claims Act program, and you might be wondering, why is she talking about a medical malpractice liability program when we're talking about quality of care? But this is a federal program that has been expanded and to include free clinics, not charitable clinics, but free clinics, to receive medical malpractice protection. But the federal program requires, if you want to participate in this program, that you have to have a board-approved quality assurance plan and also meet some other requirements in terms of credentialing and privileging. So I turn to this to suggest for all those clinics, and I think at this point there are close to 200 clinics that have been deemed under this program, that they at least have processes in place to help assure a high quality of care. Evidence, I have to admit, is thin on this question, what's the quality of care at free and charitable clinics? But I like to look to what's being accomplished in North Carolina. The state association there has had a long-standing partnership with Blue Cross Blue Shield Foundation of North Carolina, and through their partnership embarked on a really ambitious initiative to collect outcome data. So North Carolina, despite its small geographic size, has lots of free clinics, I think over 50 at this point. And so what the foundation money has led the state association to do is require their member clinics to randomly select 50 hypertensive patients and 50 diabetic patients and report on their outcomes. And this table is summarizing just a few of the outcomes that these clinics are required to report on. And I'll just pick out a couple. So in the second row, we look at the percentage of free clinic patients whose A1C is below 7, so suggesting this person is well controlled. 43% of the free clinic patients in the sample have well-controlled blood sugar. And this is absolutely comparable to what we see in the third column, which is HRSA, North Carolina, which is the health centers. So completely comparable to rates seen in comparable settings. If we look down at blood pressure under control, fully 2/3 of the free clinic patients had their blood pressure under control, and they actually compare favorably to their health center counterparts if you look at the third column. So all to say, when we've looked below the hood, the free clinics show that their quality of care, at least on some of these chronic disease measures, is as good as other settings. But this is where, when I ever have an opportunity to tell a clinic like I did earlier today before I started my talk, there's one thing you can do, is collect data to show the quality of care you're providing. That's just absolutely essential in today's environment. We also have, because we have a much greater focus on quality these days, the story isn't just about volume, it's about quality, that clinics have, through their state association, developed their own accreditation or certification or recognition programs as a way to signal that this clinic is providing high quality care. So in some cases, some clinics have pursued national recognition through programs like NCQA, but other clinics have worked through their state associations to provide recognition programs that are tailored to the free and charitable clinic settings. So turning a moment from just quality to sort of cost and quality, there was a 2012 study in Virginia that looked at and compared users of a free clinic to non-free clinic users in terms of their ED use, and found that the free clinic users were less likely to show up at the ED with lower levels of care. Right? So we don't want patients to show up at an ED needing things. And what we found is that the free clinic patients reduced the low levels of care, reduced the frequency of low levels of care. What they didn't accomplish is there were no differences in avoidable hospitalization, avoidable ER visits, but just the lower levels of care. So we're partway there. And then in Georgia, some economists look at the return on investment in managing hypertension patients and found that for every dollar spent on hypertensive management in the charitable clinics in Georgia, it yielded a savings of $1.60. So this is the kind of evidence that I think really is needed across the country. But when we've looked, we've found evidence to suggest that there are processes and a suggestion of good outcomes among patients who are served by the free and charitable clinic sector. So hopefully I've convinced you that free clinics are significant, that they're a permanent part of our safety net, and they have at least the ingredients to provide high quality of care. You still might be asking, well, do we still need them after the ACA? Let me give some perspective on that question. When I started talking about the history of free clinics as gap fillers, I want to start this part of the conversation focusing on three kinds of gaps that free and charitable clinics can and do fill. We have gaps in coverage, we have gaps in services, and we have gaps in the availability of providers. I'll mention very briefly that I think another defining characteristic of free clinics help to assure their survival, and that characteristic is the fact that they're volunteer-based. And the third is that it's free and charitable clinics that have the specialized expertise in treating the uninsured and medically underserved, and that makes them very attractive sites to training programs. So all of these, I think, combined set the stage for why free and charitable clinics are needed now and into the future. So let me start by talking about the gaps in coverage that we're faced with in this post-ACA environment. If we look at data from last year, we see that about 17 million people net gains and losses have become newly insured because of the Affordable Care Act. No doubt about it, this is a tremendous achievement. But nevertheless, we are still faced with millions and millions of remaining uninsured. And so if you look at the bars on this slide, for as long as your eyes can see into the future, until 2025, we still are left with 27 million uninsured. They're not going away. So then the question is, well, who are they? Well, the 27 or 35 million, depending on whatever year you're looking at, I like to think of the uninsured is made up of a few different categories. The first one is the unauthorized or undocumented population, and they number about 11 million. I think many people think the only people left uninsured are this group. They're an important group, but they're not even the majority of the remaining uninsured. The second group are the Medicaid eligible but not enrolled. And I had a really interesting conversation this morning about how hard it is to sign up people for Medicaid. And so it shouldn't be a surprise to any of us in this room that we do have 4.5 million people who fall into this category across the country. A third group is a catch-all group for people who find the Affordable Care Act unaffordable. And for different reasons. So the first group we have are people who live in a state that didn't expand Medicaid and are sort of twice burned because then they don't qualify for the subsidies to purchase coverage in the exchange, the marketplace, and can't afford coverage. And they amount to 3 million people. And then, of course, since we have a mandate to purchase coverage, we do have some people who are exempt from that mandate and some people who are not exempt. And so some portion of those who are exempt from the penalty are exempt because they cannot find affordable coverage. They meet the statutory definition of not being able to find coverage that is less than 9.5% of their income. But then you have people who view insurance offerings as unaffordable and don't sign up. They decide to pay the penalty, and the Congressional Budget Office has estimated that there are 6 million people who are not exempt for the penalty, don't have coverage, and fully 3 million of these will have incomes that are low or modest, below 300% of poverty. So let's sort of consider each of these populations and compare them to the record of free clinics serving these populations. So the first one are immigrants. So in my last survey I asked, do you regularly seek to serve immigrants? And this is more encompassing than undocumented or unauthorized. And just about 40% endorsed the question, yes, we regularly seek to serve immigrants. Maybe one reason why the numbers aren't even higher than they might be is we know that the unauthorized population, so this is a segment of the immigrant population, is not distributed uniformly across the United States. It in fact is concentrated in just 10, including our own state of Illinois. But nevertheless, this is a population that free and charitable clinics have targeted and have experience serving. The next group are the Medicaid eligible but not enrolled. And across the U.S., I mentioned we have 4.5 million of these individuals who could have Medicaid but don't. And it might be a surprise to hear that the Medicaid participation rate is only 67% on average. But this varies across the states. We're in a state, actually, of Illinois, we do better than average for once. We're at 70%. So 7 out of every 10 people who are eligible for Medicaid in the state actually get it. But that means 3 out of every 10 don't. So we have to remind people how hard it is to get people signed up, want to be signed up. And I did a little back of the envelope math calculation to figure out how many people does this translate to. What's that 70% represent? Looking at some census data about our adult population. And that amounts to about 345,000 adults. So there are a lot of these walking around. You know, the real question has been and continues to be, will this care be affordable? We don't have the answer yet to this question. But we do know with data now coming in that we have large numbers of people who are uninsured who would be eligible to purchase coverage in the marketplace but are not enrolled. And it's no surprise to see that the principal reason is because of concerns of affordability of coverage. And you just have to look at who this 10 million people What are they composed of? Nearly half have incomes below 250% of poverty. An additional 30% below 400% of poverty. So this is an issue mostly driven by concerns of affordability. And of course, we have to go back to those poor, in all senses of the word, people in states that didn't expand Medicaid, and they can't afford to purchase coverage on the marketplace because they're not being subsidized. So that accounts for the 3 million who are located in those gray states, and then Idaho gets to be brown. Those are all the states that haven't expanded. So let's look at this question from the perspective of a free clinic patient. So here's one anecdote that I'll share. So this comes from a free clinic in St. Charles. And apparently, H&R Block, when it does your taxes for you, it also gives you this nifty little handout that shows how much you would be asked to pay for coverage using the middle silver plan. And so this patient of Tri-City Health Partnership Clinic brought this piece of paper in and was, and I'll use the technical language that she did, freaked out that he, with an income of $17,000, had to figure out how to come up with $56 a month to afford the premiums to purchase and coverage, and was very concerned because the clinic's eligibility criteria was such that if you have insurance, you could no longer be seen at the clinic. So it really puts the free clinics in a very difficult position, wanting to promote coverage for any patient who would be eligible, but at the same time worrying about what that means for that patient to participate in the marketplace. Concerns about affordability extend not just to premiums, but to other cost sharing, right? And here, this is some data from a Kaiser Family Foundation survey where 20 and 30% of people were very worried about the ability to afford prescription drugs and other healthcare services they needed. So these are real concerns that are felt across the country. What's free clinics' experience in serving this population that we might be calling underinsured? You know, they have coverage, but they might not be able to use it. To be honest, I don't know what the current experience is, but when I surveyed clinics back in 2006, very few clinics served patients who carried insurance. If you see here, only 22% would see an underinsured person who had an uncovered service, or another 20% who had unaffordable coverage. It'll be interesting to see, because I'm administering the survey again this year and have been doing it since last year, if this has changed, if the underinsured are now welcomed more into the free and charitable clinic sector. So besides gaps in coverage, we have important gaps in services. And chief among them is the lack of coverage for adult dental services under the Essential Health Benefits Package. And then skipping ahead to the third kind of gaps that we have as a consequence of the Affordable Care Act, real or potential, are gaps in the availability of providers. So the Association of American Medical Colleges has estimated a shortage of some 46,000 primary care physicians over the next 15 years. And if we have a shortage of physicians, this will lead to longer wait times to receive care. And we already are seeing reports out of states like Massachusetts that have had health reform for a number more years than we've had across the country, and we're seeing exactly that. That there was one study I read with 49% of family physicians not accepting any new patients. They were full. And that has to translate to longer waiting times for anybody else in the queue. So this is something we need to pay attention to and find out how this primary care physician shortage is playing out in your particular communities. Another part of this equation comes from downward financial pressures on the health sector, the health center sector. As I'm sure you know, the federally qualified health centers, the federal program, is the largest delivery system for people who are poor or uninsured, and the Affordable Care Act has invested $11 billion to expand that program, but they are facing downward financial pressures in part because of the failure of 23 states to expand Medicaid. If a health center is also in a state that hasn't expanded Medicaid, they're going to have to spend their dollars not on adding services or adding new sites, expanding their capacity. They're going to have to spend it on people who are uninsured. Another problem that health centers are facing is that they are being left out of provider networks. So if they're being left out of provider networks that they don't have exposure to and can't benefit from the newly insured who have commercial insurance, but the federally qualified health centers have to treat all regardless of ability to pay. So what potentially can happen is that somebody shows up, they might have insurance, but the FQHC is not in the network, so it's not going to see any reimbursement from that visit, but it's obligated to serve that patient. So all to say that all of those monies don't necessarily translate to expanded service. And then because health centers are a federal program, they are vulnerable to the ebbs and flows of the federal appropriations process. And I wanted to also sort of point to new evidence from a December 2015 study that looked at increased wait times to get an appointment in an FQHC, and we find that 35%, so a third of all the health centers are reporting increased wait times if they're in a Medicaid expansion state, and 20% at a non-expansion state. So just because an FQHC is in your community doesn't mean that the uninsured and low income and Medicaid population can get an appointment. They might have to wait. So this context matters because it's not just a demand question. How many people are out there that need access to care? It's who else is in the community available to meet that demand? And FQHCs are an important provider in the community helping to meet that need. But when they're squeezed, that means that in all likelihood, those patients are either going to be showing up at free clinics or charitable clinics or the ER. And we know that the federally qualified health center program is limited to only places that are designated as medically underserved. So if you're in a county that isn't designated with that MUA status, then you won't have the benefit of having an FQHC in your community. And then the reality is that there are providers who are unwilling to see Medicaid patients. There's a perception that they're just not worth the bother, that they're not compliant, and in an era where providers are being reimbursed based on their performance, based on outcomes, they may be even less inclined to want to invite Medicaid patients into their panel if they are more difficult to manage. So again, let's return to the free clinic in St. Charles and think about what does this mean for a patient who becomes eligible for Medicaid. So we are in a state that has expanded Medicaid. But St. Charles is one of those places where it's very hard to find a Medicaid provider accepting new patients. And so again, this was a difficult situation for the free clinic to know how to proceed, because this patient, on the one hand, has an insurance card in his back pocket, but doesn't have a way to access care. And we only have to look at the experience in Massachusetts to know, in a state that has expanded coverage where close to 95% of the population has insurance, that doesn't necessarily equate with access, that people either delay or go without care for a variety of reasons, many of which are due to cost. And then our state association here in Illinois, when we conducted our state survey in 2014, asked clinics to tell us about the experiences at their clinic about the ACA, and confirm for us some of the things that I've already talked about so far, that bronze plans that have high deductibles basically aren't providing access to care. It's very difficult to navigate the Medicaid bureaucracy, and this leads to delays, so that somebody who's eligible may not get the care, at least not quickly. And what do you do with them in the interim? And the insufficient supply of providers willing to see Medicaid patients is a real issue here in our state. So the second dimension that I want to mention that I think helps to make the case why we need free clinics now and into the future is that free and charitable clinics help to enhance our whole civic life through its focus on volunteerism. And you don't have to look very far to see reports like this one described in academic medicine from a medical provider who talked about and wrote quite eloquently about his experience in volunteering at a free clinic and how this provided him with this supportive milieu, how it allowed him and others like him preserve their clinical skills. And then ultimately, he reflected on, as being a volunteer and not in a productivity-focused environment, having the luxury of time to spend with the patients, and how these long conversations can allow that provider to have a much broader assessment. So this, to me, speaks to a really important ingredient to high-quality care. That if a provider has the time to spend to figure out what the problems are, it certainly sets the stage for a high-quality encounter. So I think the volunteerism aspect of the free clinics is undervalued and should be recognized and applauded. And then we shouldn't forget that given our 50-plus years history of serving patients who've been neglected by the larger system, has given free and charitable clinics specialized expertise in how to treat these patients, and has made them very attractive training ground for medical students, nursing students, and the like. And we don't need to look very far to find study after study after study showing the benefits of training in a free clinic and what that does for those that have had that exposure in terms of their better attitudes toward working with underserved populations, wanting to practice in medically underserved areas. And if we're thinking about what's good for our society and are very serious about addressing our health disparities, we want to attract people into underserved communities, and we want people to want to have in their patient panels Medicaid patients and other vulnerable populations. And if free and charitable clinics can help open those doors, that should be encouraged. I'm looking at the time. I wanted to talk a little bit about some other work that I've been involved in, but I think I'll just save it maybe for another conversation about what I'm seeing about how free and charitable clinics are faring under the Affordable Care Act. We have some evidence from a survey that was conducted by AmeriCares of its member clinics, but I'll save that slide for maybe discussion one-on-one or a later opportunity. But would want to close with this message that I think free and charitable clinics are our litmus test to the success of our reformed health environment, because what free and charitable clinics provide, where they're located, the patients that they see, I think all help us expose the gaps in our health system. So thank you so much. We have a few minutes for questions. I'm happy to entertain any. Yep.
So under the ACA, with the community health needs assessments that hospitals are obligated to undertake, are they drawing on the experience of free clinics? Are they recognizing the gaps, looking at the populations, finding ways to strengthen or collaborate with free clinics?
So I don't know if everybody heard the question, but the question is, since hospitals have to conduct a needs assessment, have they become aware of free clinics? I think it gets to your question. And while I haven't been involved in that work, my impression is that those needs assessments are very limited in scope to just the patients that system serves. And so they don't really look outside their system unless they have to. So it has to be very deliberate. So I would say I'm probably suspicious that much has been learned through that community needs assessment process about community partners and the plight of the uninsured, because they've defined their patient population as those who are users of their system. So sorry to be so negative about it. Yep.
By and large, I think this is a slide to skip. By and large, what is the most frequent source of funding?
Individual donations.
Individual donations from small donors?
I can't tease it out any finer than that. When I ask clinics to check the box, where are they getting donations? Individual donations is the most often checked box. And I separate that from corporations, from United Way, from hospitals. So whatever clinics, how they might interpret individual donations. But I think a lot of that does come from single donations.
As opposed to patrons or anything.
Right. Yep. Oh, no, so it would come from individual patrons.
No, but I mean into the technical section, the aim of the large donors, the person who has $5,000.
Yes, probably. Yeah, it certainly would be reflected in that category. Yeah, sorry, I wanted to come back to that.
You mentioned that if the free clinic or charitable clinic follows federal guidelines, there's immunity from tort claims. What percent of the clinics have actually gone through those, and what percent haven't?
Yeah, I was going to send an email to HRSA yesterday, and I forgot. The last I checked, there were, I think, if memory serves, only around 165 clinics that had take advantage of that program. It's limited to free clinics only. So they don't recognize charitable clinics. And some of the advocacy work that the National Association of Free and Charitable Clinics is doing is to try to expand that program so that more and more clinics can participate. Because if you charge your patients a fee of any kind, you cannot participate. And so that's excluded a lot of clinics from being eligible to participate. But even if you would say that there are only 1,000 free clinics, those who don't charge a fee and only ask for a donation, and donations are allowable, you're still only talking about 15%. So this is a program that I think is, unfortunately, a best kept secret. And I wish there was more awareness about it so there would be greater take-up. I think there's also an impression that there's a lot of red tape to get it. But for those who had that impression and then went through it said, wow, that wasn't so bad. So I think if you're a clinic, you should look into it if you haven't already. If you are a clinic that is a free clinic. Yep.
So is there a demographic breakdown of the free clinics with this survey demographics?
Of free clinics versus charitable?
No, I mean the patient in this survey. The demographic.
By and large, free clinics are targeting their services to patients whose incomes fall below 200% of poverty. It's an adult population between 18 and 64. Minorities are disproportionately represented, although the last time I looked, exactly half of free clinic patients were white, although the percentages of minority patients were represented at twice the rate that we find in the population, so disproportionately served. A little bit more female than male, just to give you some sort of big picture. Mostly uninsured, largely uninsured. It'll be interesting now because I asked these same questions again in the 2015 version of the survey, how demographics might have shifted. I'm interested in particular to see if some of the income thresholds have moved, because some clinics have had their threshold at 100% of poverty. We have to remember in some states that haven't expanded Medicaid, the percentage of the poverty rate is like 29, you have to be at 29% of poverty or 64% to be super, super, super poor to get Medicaid.
Have you looked at the numbers of the free clinics coming up in 2015?
I'm still working on that. And the survey is still very much alive. And hesitate at this juncture to predict where we're going to end up. But because I've expanded my definition, I expect that, and if I had to guess, it'll be over 1,200. But that's including charitable clinics too. And we're seeing movement across the sector from a free clinic wanting to become a charitable clinic. So it's not all new clinics entering the scene. It's a change in organizational form.
We at Avicenna have seeded or at least contributed to establishing of 2 other clinics.
Thank you for that.
One just coming up in Peoria, Loyola.
Okay, I'll have to make sure I have them in my database so I can make sure that if they've started operations that they're included in the survey.
They just first one is already doing it.
Okay.
Second one, Peoria just
Yeah, because this is a population survey, so my interest is in capturing every single clinic that would meet the criteria as a free or charitable clinic to have the opportunity to participate. Okay, thank you so much.
Thank you.